For 2 days, pediatric ethicists, researchers, and medical experts from the United States and around the world gathered at the Bell Harbor International Conference Center in Seattle, Washington, to discuss the difficult and challenging ethical issues surrounding prenatal and neonatal care.
In neonatology, there are more and more ethical dilemmas as we push the lower limit of viability.
The issues of how parents interact with neonatologists to make decisions regarding their babies are very important to my work.
The Truman Katz Center for Pediatric Bioethics at Seattle Children's Hospital presents its 6th annual conference, Tiny Babies, Large Questions, Ethical Issues in Prenatal and Neonatal Care. The Truman Katz Center is the nation's first center dedicated solely to the study of ethics relating to research and healthcare for children.
So what the heck is an obstetrician doing speaking to a bunch of pediatricians? How did I wind up here in Seattle all the way from Boston? I did not come with the Red Sox. I joke with Doug Diekema that I was brought to explain to you all why exactly obstetricians don't count so well. And the case that brought this to a lot of folks' attention is before you here. About a year and a half ago in California, octuplets were hatched. And you'll remember the details of the case. They actually thought that there were 7 inside and were surprised when at the time of her cesarean delivery, not forced, I understand, an 8th came out. And this raised a lot of different questions, and I will try to address some of those questions for you today. I am at best an amateur ethicist. Clinically, I am used to being told by pediatricians all the time when and how I've got it wrong, and I'll be glad to hear during the question and answer session from all of you exactly how I've got it wrong. When the octuplets were born, at least to judge from the attention in the media, the letters that were written, the commentators on television, there were 2 sorts of questions. The first sort of question came from many in the public who were outraged that we, my colleagues, let her be a parent. The details that quickly became apparent: she was single, unemployed, had 6 other kids at home. How could they help her have more, much less 8 more? Another question raised on large by people in the business, maybe many like you, which is the counting question. Why exactly did they put so many back? When I first heard about this case, I assumed that it was a case of ovarian stimulation, right? Clomid gone wrong. Because surely we can control with IVF and choosing the number of embryos that go back and avoid cases like this. And I was surprised to find that in fact they had put 6 embryos back, and unexpectedly, but not so terribly unexpectedly, 8 had resulted. Our discussions, you've heard this alluded to in several other talks today, our discussions will inevitably focus on questions of duties to whom? Mothers, fetuses. This is a difficult question, and one that certainly I'm not going to be able to resolve, in the time allotted. And I'll try to finesse it a little bit by pointing out to you that in this situation, at a time when decisions like this are made, there are no pregnancies. No one is pregnant. There are no fetuses. There are embryos, but they are literally embryos in a dish. And there are no children. There is only a potential. All these will disagree, many in this room, about what rights are appropriately afforded to fetuses in utero. And it also, I believe, is an impossible question to reconcile. Impossible, at least in part, because it's linked to the third rail of these debates of pregnancy termination, of abortion. But I think we can all agree, and I remind you that in this case, the rights of women, including in women who are anticipating pregnancy, I don't think there's any debate or discussion about that. We heard Mark talk about it a little bit before. I don't think we argue a lot about what the rights of women anticipating pregnancy are or are not. When we think about should this patient have been a parent, should someone undergoing IVF be a parent, I think we should also recognize that in general, our duties as providers are to individual patients before us, and we're not there in many cases to enforce society's agendas and missions. We think about cost, but put very nicely before, we try to think about it on large. as a matter of policy and not focused on an individual patient, right? We're saving money now and we're saving it with you. That's generally not what we do. There are other tools that we use to accomplish public health ends. And we'll talk about some rare exceptions about duties to evaluate fitness as parenthood. But I'm going to argue to you that these, in most cases, are very rare. At least that's how we see it on the pregnancy side of things. In part, the challenges with obstetricians, IVF doctors serving as gatekeepers are that it's very difficult to evaluate an individual's appropriateness as a parent, right? You would have guessed that I'd be a rotten parent, but in most cases, people can't guess that. And these aren't skills that most of us as physicians are taught in medical school or residency, not really a tool set that we have. And we really do want any such evaluation to be objective. And that really is a challenge because we all have our own notions about who we think should and should not be parents or what kind of parents they are. And often these notions are ill-informed and prove not to be the case, not to be true in the long run. And there are also very core issues of justice here. If we're making this evaluation, why is it that we're making it only on a set of people that because of medical conditions, circumstances, require the use of assisted reproductive technologies, right? I'm not making these evaluations in general on all people who come into my office and say, boy, I want to be pregnant. Because most of the time, they don't come into my office, right? We've all had occasions, you as pediatricians, I as an obstetrician, to say, oh, I can't believe it. How is this person going to be as a patient? And it's fun. We won't do it much here, but you can do it later when the conference is done and you're out in the sun and you're having a glass of wine or a beer and think about the slippery slope here, right? Where would you take this obligation? So I have someone that comes into my office and maybe she's a 17-year-old who hasn't finished school and she says to me, I want to get pregnant. Can you tell me about the folic acid I'm supposed to take and the prenatal vitamins? Should I not tell her those things? Should I say, I'm not going to tell you about that because you might then actually go ahead and get pregnant, so I'm not going to do that. Or someone that says, I want to stop my birth control. Or let's take it even further. Do we have an obligation to have people on birth control? And we know where that argument has gone historically. So it really does open, at least, again, with one glass of wine or several beers in you, a fun, slippery slope to explore. And this just reminds you that, we don't, in general, set this bar, this threshold for people that just go ahead and get pregnant the old-fashioned way, right? We don't scrutinize their fitness as parents. And there are some exceptions. You'd say to me, well, we don't have the opportunity. But your colleagues who practice in ART, who do IVF, they do have an opportunity. And the ASRM, the American Society for Reproductive Medicine, has offered some guidelines, a very high bar. They say there needs to be a substantial, non-arbitrary basis for thinking that parents will provide inadequate child rearing before they advise their members not to afford prospective patients the services they are seeking. I think the key here is that they're really looking for dangers. As examples of dangers they offer, someone who has been convicted of child abuse before. And they suggest that people really need to be mindful of conscious and unconscious biases that might affect decisions here. John Robertson, many of you know, a lawyer in Texas, has suggested that procreative liberty should enjoy presumptive primacy. I think what he's saying is that we really need to be careful about how we restrict access to these services, access to parenthood. And so to conclude this portion of my talk to you today, I'd make a pretty strong argument that this patient's needing IVF, her circumstances, that really, although it provoked a lot of the outrage, that was really not the issue in should she have been pregnant. I think the issues surrounding counting are really more germane here. I'm going to, in the next couple of slides, take you through quickly what a lot of you already know. As you put back more embryos, you pretty quickly reach a plateau for pregnancy. That plateau varies a little bit. Older women are less likely to get pregnant, but you see someone here, 30 to 35. By the time you've put 3 embryos back, you're not moving the bar very much. The bar that you are moving, however, is the multiple births bar, right? So the more you put back, the more multiple gestations, triplet or higher order multiple gestations in particular, you get. And you know this as well, if not better than I. The more you have, singletons, twins, triplets, the earlier you deliver. Right? And we can see that presented graphically here in another way, right? Less than 32 weeks, triplets, a third. You know, by the time you get to quadruplets, no one goes to what we would recognize as term. We're going to focus on triplets and higher order multiples today, but twins ain't nothing, right? You all know that, and we'll look at a little data there, but the focus is on octuplets and quadruplets and triplets, but we should be paying some attention to our twinning rate in this country as well. Small graphs because they're obvious. The earlier you're born, the more likely you are to die, retinopathy of prematurity, RDS, sepsis, a whole host of things that all of us in this room are about avoiding in any way possible and treating, we hope not. So some specific risks of multiples. For triplets, average gestational age 33 weeks, quadruplets 30 weeks. Look at days in NICU. Average length of stay in the neonatal ICU. Numbers needing NICU care. Risk of CP for triplets, 17 times more that of singletons. Right? Triplets. No one blinks an eye so much about triplets, certainly not twins. 4 times the risk of CP. Okay, so I don't think I need to go on and on to convince you that there are risks to multiple gestations. And there are alternatives. Alternatives, SET, single embryo transfer, has been well studied. This is how it works. The idea is that in appropriate candidates, you put one embryo back. If a pregnancy, and you freeze the other healthy embryos, and if a pregnancy doesn't result, then a month or 2 hence, you go back through a frozen cycle and return another embryo. Doing that in appropriate patients, and we can talk later about what appropriate is, but very similar rates of pregnancy, not statistically different. But look at how much lower the rates of multiple gestation are. And people have subsequently showed that you can improve these rates by very carefully choosing which embryos you return, essentially letting the embryo develop even longer to the 5-day blastocyst stage and choosing what by a number of criteria under a microscope seems to be a healthy embryo. There are guidelines from the ASRM, clinical guidelines, about how many to return. They recognize that higher order multiples are an undesirable consequence, so triplets and beyond. Separately, we can talk about how undesirable twins are. There's some disconnect there between what all of us think and what patients think. Patients often tend to look forward to twins, right? Get it over and done in one shot. So much the better if we give you a boy and a girl and a dog to take home as a prize. But here are, and the numbers should be agreed upon in advance. So there should be a conversation here. It's not just about what the doctor thinks or wants. And you can see that these numbers are relatively low. So blastocysts further along in culture are more likely to result in pregnancies. That's why there are lower numbers. Younger women more likely to get pregnant, in part because of the embryos, some related to the uterine biology as well. And so fewer numbers here. And they divide it into those who are favorable. They're young, maybe they haven't failed a number of cycles, no other issues, and or less favorable. Take a look at those numbers and you'll see, well, I guess it's not this pond, we're in the Pacific now. So across the Atlantic in the UK, there are some other specific recommendations. These recommendations have a little more force over there, and we'll talk about why in a second. But first of all, for anyone that's doing this kind of work, there's a requirement to document a strategy to reduce multiple births to no more than 20%. Transfer of no more than 2 or 3 embryos, depending on age, and document, if patients were appropriate candidates for single embryo transfer, why single embryo transfer was not performed. So, not only more restrictive guidelines, but these are real requirements. And we'll talk about how is it that there are requirements there and not here. I think first, because this isn't just a talk on IVF, it is a talk on ethics, we should pay attention to some of the arguments that can be made ethically for limiting numbers. We've spoken a lot this morning about risks to multiples and prematurity, but there are some real risks to mothers of multiple gestation, right? I'm looking at Elena Gates, who may be the only other obstetrician I recognize in the audience, but she knows, I know, multiple gestations, risks for bleeding, preeclampsia, gestational diabetes, cesarean delivery, preterm labor requiring modification of bed rest, so real risks to mothers. So separate from any obligation to a fetus or a pregnancy, multiples carry a risk for mom. Also, multiples are not, especially higher order multiples, are not generally concordant with the goal that most women, most parents have in approaching IVF, right? Having a healthy child. I've tried to argue to you that higher order multiples actually probably fight against that in many ways. Mark spoke about the principle of respect for autonomy and how that's the core of what underlies a lot of the ethical guidance, at least ACOG offers. You all know, and I'll remind you, that respect for autonomy is not the same as autonomy. We don't have to do what our patients want. If you're treating someone for leukemia, and you say, okay, I'm going to give you this dose of this, god-awful medicine, and the patient says to you, well, I really want to kill this leukemia, doc, so give me twice the dose. You're not obliged to say, okay, you want twice the dose? Great, we'll just, pump it into you, right? So respect for autonomy, involving patients in decision-making is not the same as, well, you pick how many embryos you got back. And that was part of the argument that was made in the octuplets case. And so I think there are guidelines in this country. There are reasons, ethical, clinical, to argue against putting a lot of embryos back. And yet you'll see here, in the last data I have is 2005, but you'll see here that in 20% of the cases, 4 or more embryos. We're getting better at single embryo transfers, but not so much, less than 10% in this country. I don't know the equivalent data in the UK and other places. I'm led to understand that the blue and the red, the blue's much higher, and it's all blue and red there. So why is there this disconnect? Why, if clinically, ethically, what's going on? Well, some of it is that the folks, the providers who are helping with the IVF, they then send them to me, right? I inherit the quadruplets and the triplets, so I'm not part of that initial conversation. And then, of course, before you point it out, I recognize that I then give them to you, right? Here are the 28-week triplets, good luck, see you later. So there really is, we heard before about, teams and shared decision-making. That does not happen here. It is very much in silos. And different people and different patients will have different notions about what status and what respect should be afforded embryos. And for some patients, it is simply not acceptable to have frozen, unused embryos. Right? For some individuals, those are the equivalent of children, and so they feel that they must take them back. Now, I would argue to you that knowing that about a patient should affect how many you create and when you create them. And there are other creative ways in which that wish can be fulfilled without resulting in many pregnancies or multiple pregnancies. But that is why some patients feel strongly about getting embryos back. And then, of course, there's the elephant in the room, which is finances. Right? There are, I believe, last count, 3 states in the country. I live in one, Massachusetts, Illinois, and Hawaii, in which IVF is mandated as a regular part of insurance coverage, not provided, at least as I understand, not in Massachusetts, as like Medicaid benefits, but if you are a private insurer in Massachusetts that offers healthcare insurance, you have to have ART IVF as part of the benefits that you offer. But each time a patient goes through this, they have to fork over a lot of money. So it's easy for me to stand up here and say, well, you just do single embryo transfer, and if that doesn't work, then you go through a frozen cycle, but who's paying for that frozen cycle? And so patients place a value on getting pregnant and getting pregnant quickly. What I would argue to you is that discussions need to happen, and they need to happen up front. Look, I'm not saying that you can't ask patients to consider the challenges and realities of parenthood. Right? We have connections with our patients. We're in a relationship with them. And so we can ask them to consider those things, particularly as it relates to multiple gestations. And we need to discuss those risks very clearly. This is why I would not recommend that we put back more than one or two. We can, of course, and I've not done it today, but we can, of course, talk about the option of fetal reduction, multi-fetal pregnancy reduction. But as all of you recognize, it's nothing anyone can mandate in advance. And many of you have seen patients who up front think one thing and then do another. I will certainly reduce from triplets to twins. No, I can't. Or I would never. And I'm pregnant with triplets, and I guess I got to think of it. It's real in another way. And then careful planning in advance about the number to transfer. What about regulation? Kind of a blunt instrument here. Before you are two editorials. On your right, one I wrote with a colleague, Howard Minkoff. On the left, another written by my colleague across town, Lynn Ginsberg, who was president of the ARSRM at the time, that appeared in kind of our rival journals. So the Green Journal and the Gray Journal, American Journal of OBGYN and Obstetrics and Gynecology, within a month of each other. And presenting very different perspectives here. So the reproductive endocrinologists, the IVF docs, thought that regulation shouldn't happen. That it ignores the success of professional standards, and that it opens the door, right? It lets the elephant's trunk into the tent. And if you're regulating this, then soon what will you be regulating? And what we need is a dialogue between patients and providers that lets people make decisions together. Howard and I, we're not IVF docs. This isn't what we do. But from a distance, it seemed to us that it may be the time to begin to think about regulation. Think about it because, at least looking at the numbers, a lot of embryos are still being put back. Thinking about it because we hope that in some ways, regulation would make things a little easier for our IVF colleagues, right? We have rules. I can't do that. Here are the rules. Not just guidelines, but there are rules. And also, there's a sense of justice, of everyone being treated the same, that it doesn't depend on, you don't like this doctor, so you'll find that doctor who your friend didn't have access, or you can twist their arm or find a way to get your way, that it's fairer across the board, and no one's having access or not to different services. There are many, many, many problems with regulation, and I hardly pretend to have worked out the details or can even tell you exactly how I would go about doing it. It is not the way of American medicine to be highly regulated. We offer a fair amount of freedom for good reason to each of us, to all of our colleagues. It's difficult to imagine exactly what the nexus, the tool for regulation would be. In many countries, in the UK, for example, it's payment, right? If you're paying for this, the health authority, National Health can say, we will pay for you to return no more than 2 embryos, over and done. But we don't do that here. That brings up topics like rationing, which almost killed healthcare reform a couple of months ago. The FDA does have rules for tissue product regulation, including rules about what kinds of tests need to be done on people undergoing IVF. Maybe that's a potential avenue. Facilities are licensed. licensures or memberships in societies or state licensure for individual providers. But it's difficult. Before I came, I looked up, what happened to the Octomom doc? Well, he's before the board of California again, because subsequently he put 5 or 6 back, and there was a woman with quadruplets that had a not great outcome. Professional societies are not well equipped to kind of beat people with a stick or make people toe the line. It's a difficult thing to do. So in summary here, the ethics of octuplets, I think we need to distinguish what the questions are. I would argue to you that the more approachable question, the more appropriate question from my perspective is focused on the risks of multiples and not the issues of who and who should not be parents. Again and again today, we've talked about encouraging education and dialogue, and I will add to the list of those encouraging such. We certainly need to promote and publicize guidelines, and I think it is time to begin to consider difficult, admittedly, but maybe necessary things like regulation, and we will work to have all of my colleagues do some remedial mathematics. Thanks very much for your attention today.
You talk very well about sort of the 4 cornerstone principles of bioethics, autonomy, justice, and so forth. But the other thing we use a lot in ethics is talk about benefits versus burdens. And I don't think there's any question in the forced C-section example that that's a very significant burden on the mom under any circumstance. But there are other situations, and the one that our NICU tends to be filled with is babies from drug-abusing mothers, where saying that a mom should avoid drug use, illicit drug use, during pregnancy may not be as much of a quote-unquote burden on her. And yet this is also a very large ethical dilemma that we have. So and I know that there are situations where, and once again, this tends to be poor minorities where women are put in jail so that they won't use drug use or other things that are also be a significant burden. But I'm just wondering about your perspective on the ethical analysis of the burdens on the mom of avoiding drugs even though she wants to use them.
It's an excellent point, John. With regard to illegal drug use and addiction, the adage which you know well, and I'm sure many people in the room know well, that ought implies can, which is to say that a heroin addict is obligated not to use heroin is to suggest that that's something she can do. Now, certainly she can get methadone, et cetera, but you get my point. With addiction is a bit of a difficult case because it's not a totally voluntary behavior commonly. Moreover, I think that I would tend to agree with those, including Harris and those who lean more toward the maternal-fetal relations, that we're going to get more mileage. There's going to be more, in the end, we're going to do better for the babies and the moms if we work on a preventative approach rather than a punitive approach with regard to many of these things. And we certainly don't want to do things that are actually going to drive people away from prenatal care, which is the other fear. But your point is well taken. I use the extreme case of the C-section. It becomes a much murkier, all the way down to the Connecticut cream, to make the point that that's the far end of the spectrum, but that it becomes murkier. But I do think addiction is a special case. And
there are some non-hypothetical cases that might come closer to meeting respect for that point. So, for example, there's some controversy now about fetuses that have a form of virilizing adrenal hyperplasia, that is, have disorders of the adrenal gland in which simple oral cortisone, or a cortisone-type drug by the mother, will avert a cascade of events that will cause malformations in the baby. So all the mother is being asked to take there is a medicine which has very minimal risks to her and can have major benefits. So that's one case in which we're not talking about operating on people. Another, to respond to Elena's comments, was a case in Michigan some decades ago in which a woman took tetracycline for a somewhat unnecessary reason. That is, there were other antibiotics that would have worked, and knowingly took tetracycline, which, by the way, causes severe staining of the permanent teeth of newborns. So her baby who sued her was born because she, quote, took away my smile, end quote. That is, brown teeth, which were very hard to fix. And it was a somewhat trivial reason for her to take this tetracycline. It's a much more complicated case, but in there the courts upheld the claim that, at least, I should put it differently, the courts rejected the notion that there was some sort of immunity, that a child could not sue his mother for something she did prenatally. And I would just put it in moral terms slightly differently than Mark did. If a child winds up being severely, let's say, brain damaged for something that the mother could have easily prevented, it may be surgery, it may be medicine, but something that is a standard medical practice and not extremely risky. And the child at age 3, 5, or 7 who's permanently disabled and asks, who did this to me? And how did this happen? And where was everybody else? And was I not entitled to any protection? I think it's not only a poignant moral claim by the child, but I think it's something that calls for some kind of a remedy in cases in which the facts are relatively low risk for the mother, high likelihood of serious harm to the child, high likelihood of benefit, standard practice, something any reasonable person would do.
The criteria that you just listed, you know, high likelihood of success, standard practice, low risk, I don't think we can think of many medical interventions.
I just named one, dexamethasone for virilizing adrenal.
I just remember reading something about a controversy over that, actually. So, anyway.
I guess, setting the ethics aside, I'd say as a practical matter, I'd make 2 points. The lower the burden and the more certain we are of benefit, the easier it should be to convince someone to go ahead and take the dex or take the steroids or do what we want them to do. And if they're not, then we need to examine our assumptions. And with regard to drug treatment specifically, I don't know how many of you have tried to get a pregnant woman into a drug treatment program. And it may be easier out here than it is where I come from, but it's near about impossible. And so I regularly see people that say, boy, I'd like to do something about my cocaine, heroin. You fill it in, and then you spend forever. So we can also work to reduce the burden, on our side.
Even aside from whether or not the fetal surgery procedures are efficacious, let's say for the sake of argument that it's been developed that they have, Dr. Gates alluded to the learning curve involved in doing these things successfully. And we just recently got ranked in San Diego in U.S. News and World Report, and the hospital administration met with us, said, well, congratulations, and we want you to be ranked higher than Seattle. So, how are we going to do that? We think that you ought to consider developing a lung transplant program. And, the pulmonologist to me was saying, well, sure, we're as good as anybody else, and there's no reason why we can't do this. But the amateur ethicist said, well, what do we have to offer that the 2 programs that are already very successful in California can't provide? That this is something that's not limited by the number of people who necessarily should do it, but by the expertise and the donor population. What, if any, ethical considerations really ought to govern the proliferation of programs for which there isn't a huge numeric need and to where the acquisition of expertise requires years and years of experience?
I guess I'll start with that. No, I'm not the apologist for fetal surgery. I remain very skeptical. I think you're talking about lung transplant. It's true across particularly surgical interventions. I don't know that we have a good way of govern. I think there's a lot of information for those who do want to understand how to manage the learning curve. Some of this came out of the whole story with laparoscopic cholecystectomy that some of you may have remember. When they went from doing large incisions to little videoscopic procedures for taking out gallbladders, there's a common condition with pretty squishy indications. A lot of centers started doing this, and adults were dying from complications as people were trying to learn to do the procedure. And there what happened was that there were some agreement on credentialing and numbers that people needed to do under proctoring before they could have the credentials to operate independently. And those numbers were somewhat evidence-based, based on number. Usually for a lot of new procedures, robotic GYN surgery is one I'm more familiar with now. One thinks of getting up to 40, 50, 60 cases with some proctoring before working independently. So I think there are norms out there. I hate to rely on the tort system to keep us in check, but I think that I'm getting shaking heads up here. It doesn't stop people. I sort of feel like it's a little mouse on my shoulder sometimes. The learning curve is a very interesting phenomenon, and doing something for fame and fortune versus doing it because there's a real human need to be spending those resources. Resources is another aspect of this. It's a very good question.
Maybe as a Canadian who the government decides everything in our country, there's pros and cons, so we can't open an NICU anywhere at the middle of nowhere just because we're a good NICU and we've got money, but there's more moms who get prenatal steroids and more moms who deliver in tertiary care and ICUs. So we have the bad of the system and the good of the system. So the government in Canada could decide that there's 2 centers and that's it, and the people who know the government might get it in their center, and there's other things that comes with that, but maybe government are solutions and also have risk involved, but sometimes solutions.
Okay, next question, please.
First, I'd like to thank the gentleman for the great question. I think the issue there is because we can, should we, but the driver in San Diego is cost and profit. And I think we can't lose that. And there is a problem. I see a tremendous ethical problem, so thank you for the question. This is a difficult issue for me to frame, and it kind of crosses over from the ethical to the legal, and I wanted to hear the panel's comments on it. The little contract and litigation law I know and that I've been taught talks about a standard of reasonableness. And as I listen to all the slippery slope conversations we get into, what the panel has brought up so beautifully, I keep on going back to the standard of reasonableness, which I understand is a legal issue. But also the standard of reasonableness also speaks to capacity, which is an underlying issue around autonomy. And I was wondering, in the framework of what we've talked about, of everyone's talked about, and I've heard the word of the panel come out, reasonable decision. How do you see this standard of reasonableness in this terribly polarized, highly commercialized population that we now deal with? And I'd like to hear your thoughts on that.
Anybody?
I'm glad to start a little bit. I think we need to be careful that reasonable isn't informed by attitudes and biases and prejudices that aren't supported by fact. Many people across the country will disagree about who should be parents, what the nature of families should look like, how many should be parents, what their sexes, ages, combinations should be. There should be 2 parents, there should be just 1. And so what seems reasonable to someone will seem unreasonable to another. And so I think, I understand what you're saying, but I think it's important to guard against the creep of reasonableness based on belief as opposed to reasonableness based on fact. And then, the other, you bring up the notion of the law and reasonableness. I'm somewhat fond of saying that ethics is about, in some sense, what's right and wrong, and ethics is not the law and vice versa. And there are plenty of things that are potentially legal that are unethical. So important to keep that in mind as well. And I've stunned my colleagues in this.
I think that that's beautifully said. I would add that We sometimes have a hard time determining exactly when day turns into night. So in like fashion, we sometimes have a hard time determining exactly when reasonable turns into unreasonable. Nevertheless, we can all agree that at 11:30 p.m., it's night. And there are some things that we will all agree on that we can all agree that while it's awfully hard to describe, and Jeff is exactly right, nevertheless, there are some things which we'll say, that's unreasonable. And I do think that should play a role in our thinking. Very hard to flesh out exactly how and when, but I do think that it's a good point, and at some level that needs to play a role in our thinking. And some things will be unreasonable to, if not all of us, damn near all of us.
I'm just a dumb lawyer, so I don't necessarily track all this stuff with the clinicians. It's interesting to me that the discussions this afternoon fairly quickly moved to clinical case decision making. And I was yearning, and maybe this follows up on what Mark was just saying, yearning for more in the way of principles. I understand that if we get more information about fetal surgery or some other currently unknown areas, it will be clearer what the decision making ought to be. But I think you've set up during the course of the day a number of scenarios where there just are fundamental conflicts between values. And I'm wondering if you think that there are principled ways to address and resolve those conflicts, which I think goes back to what John Lantos was talking about this morning, whether there are some fundamental principles at work, or is it a case that it all just depends? And all we can do is sort of talk among ourselves, and whoever's in that room in that conversation has to get to the end of the conversation with a decision.
I'll start with one area where I think I see us putting a little bounds on the gray area, and that is using the concept of suffering more intentionally when we talk to families about their fetuses, future children's, babies, and talking about suffering as something we can all agree should be avoided. And I think it is a place where people really can agree, because I don't think anyone thinks suffering's a good thing, and then it gives us a shared goal to figure out how we approach. One example.
Maybe as a physicians, I think we need facts to establish, in order, for example, to say over 50% is a good survival. I'm just inventing 50%, it could be 75. We need to know if it's really 50%, and we need to do good science to show that it's 50%. So right now, for example, to know the outcome of babies at 24 weeks, we need to know how many moms go to tertiary care centers, how many stay in the primary care centers, how many are offered a C-section, how many babies die in utero without offering an intervention, how many get a neonatal consult, how many decide to intervene versus not intervene, how many die in the delivery room, how many go to the NICU, and who dies. And at these 7 steps, you can die. And most of what we see in NICU papers is who dies after being admitted to the NICU, and that's what we give parents. So the weeding process, which is a grotesque word, but where you can decide not to intervene before, that's all scientific. So I'm not saying that all the moral dilemmas can be solved with science, but you need good facts to make decisions and not say, oh, this is 20% survival. In the Epicure study, 24 weeks, it's 20% survival because they count the kids who died in primary care settings. Well, that doesn't count. I mean, of course, if you have a car accident and you're left at the side of the street, you'll die. So when you present parents, you need to give them good facts. And I think that's what you're trying to say for fetal surgery. You need to do good science in order to at least have numbers to decide afterwards if 50 is good or 40 is good or 20 is good.
David, do you have anything to add to this issue?
Two different groups come at this, in my opinion, they come at it from a different angle. We come at it from that perspective. And unfortunately, I think that's, in my opinion at least, that's a lot of our counseling, not only prenatally, but postnatally in the intensive care unit. And we live and die by these numbers and by the science of accumulating these numbers. Once again, I don't have data and I don't know how to get the data, but most families that we counsel don't do it that way. They come at it from a totally different perspective. As I said before, if I talk to a pregnant mother, and some of the people in the audience have heard me say this ad nauseum, they'll say, you know, when I got pregnant, I quit drinking coffee, and I gave up my daily glass of wine, took my vitamins, got the right amount of exercise, slept at night, and I had a lot of strong Braxton Hicks contractions. My husband and I gave up having sex. I've done everything in my power to make this work. And now are you asking me to give up and do a 180? So, and they don't care about the data. And they don't care if it's a 20% chance. To them, that's 1 in 5. That's pretty good. So I think, yeah, we have to have the data and we have to use it, but we have to be cognizant of the fact that data appeals to us, but it doesn't appeal to most families.
When we see a patient for prenatal counseling with a diaphragmatic hernia in our center here, we know the data, and we believe actually in the academic bigger model of how do you advance the field, how do you learn about fetal interventions, how do you take better care of or try to advance the care of these children with fetal anomalies, that there should be some structured approach, and maybe a few centers maybe that's the best model, where there are dedicated centers of experts, and the rest of us need to wait and see. The challenge is that institutions, hospitals, market, it's a business, and there are, individual surgeons who seek opportunities that maybe are given a great opportunity personally to build something and be rewarded for it. So, and patients come into prenatal counseling saying, well, why shouldn't we go to San Francisco? We just need to go to San Francisco. They'll fix it. Because when they get on what they see on the internet is just what you said, fetal treatment centers. So we find ourselves discussing the role of fetal surgery as a non-practitioner, and it almost feels like we're trying to convince them not to have what is already accepted as the best treatment, and it's not proven to be so. I think the broad public understanding is that, yeah, why isn't everybody doing it? And they don't see the risk. So I'd be interested to hear your sense on just the conflict really between marketing and data, evidence-based data in terms of making clinical decisions.
Could I first, thanks for being a good sport. Second, if I were to suggest to you that neonatologists are really better at this than surgeons, you'd know that, come on. You're absolutely right. We joke about neonatology being evidence-free medicine. We've got good solid data for like surfactant and 2 or 3 other things, and we think we're scientists. But the fact of the matter is that we face, even in a non-procedural field, although neonatology, we can say, is a semi-procedural, certainly not on the scale or the level that pediatric surgery is. So it is true that multi-center studies take on a different feel. One can still randomize within each center in a multi-center study to account for that to some extent. But nevertheless, we face the same issues in neonatology. Should we give nitric oxide to preterm babies? Well, we could just do it, because it seems like a good idea, and they're doing it someplace else, or we could say, no, we've got to take part in a trial. Otherwise, 20 years from now, we're going to be doing it and still not know if we're actually helping or hurting here. And so we do it. I appreciate your thoughts on this, and you're quite right. And I mean, what I told the guys between the break is that the stereotype is the surgeon who wants to go forward, and there's also the neonatologist is sitting there in the bow tie saying we can't do it till we have 6,000 more data points, and we never want to move, and you guys are trying to fix the problem. So I think that together we can work through these. But I do believe that as best as possible, we have to do these randomized controlled trials. And as much as the families may not look at this on a data basis as much as we do. I think part of our job is to help them understand that that's important. If they found somewhere on the internet that somebody's doing coffee enemas for diaphragmatic hernia, and they say, why shouldn't I go to X city and get a coffee enema for my child? It's our job to tell them, no. And we're not going to start doing coffee enemas here because they do it someplace else. If someone wants to do a trial of it, we'll talk about that. But that I think it's our job to actually share with them the information and let them know what is and isn't a proven therapy, understanding their desperation. But that's part of our job in counseling them, is to tell them. Some things, if seem like a good idea, they make sense physiologically, but there are no data. Some things have been studied and shown to be of no value, and some things don't even make sense physiologically, and I think that that's part of our job to counsel them for those. As far as the marketing issue, I don't know if Elena wants to address that, but I mean, I'll address it briefly. The easy answer for me to sit up here is to tell you that you've got to forget about the marketing issue of this, and you've got to tell people the truth. And sometimes that means that they're going to go somewhere else. But the alternative is to do something that either is inappropriate medicine or that we at our place are not qualified to do. And this is not just about fetal surgery. This is about, in pediatrics, this is about opening up an ECMO center when there's already one 2 miles away that's barely got enough cases to keep competent. Do we really need another one? Or does that just mess up the care in both places? It's about all sorts of things. It's about opening up another newborn intensive care unit when there's one a mile away. Do we really need another one? And this was Annie's point about in Canada, where there's a bit more control, they can be a little bit more intelligent about this. But I appreciate the situation you're in and that you're looking at this thoughtfully and trying to negotiate these waters. But I think in the end, you still have to tell people the truth about what's been shown to work and what hasn't.
I'll just add, I think your comments were great. So thank you for speaking up about all those issues. On the marketing, I think, speaking as a physician that works in a large medical center, the medical center holds the resources, and as the physicians, it can be sometimes difficult to push back against those strategy guys in the medical center who want to build this, that, or the other program for some goal that's not necessarily about health care. And I think we have a responsibility to do what you said and sort of push back and say this isn't a good idea. Another thing in terms of the randomized trials, I'm not optimistic that we're ever going to be able to do randomized trials of surgical interventions for a lot of reasons. I do have optimism that some of the decision science and biostatistical understanding that's evolved over the last 10 years or so may get us closer to be able to look at the data that we can collect to understand what it means. Meta-analysis, for example, is a tool that's come up in the last 20 years that I think has been pretty informative at putting together a bunch of not so great data and getting something that at least, well, bad data yields bad data, but I think some of it's useful.
I guess I would really rail against the idea that a broad public understanding of something that's beneficial or not beneficial is a reason to do it. There was the little letter that came out in the New England Journal in 1996 about the public perceptions of CPR and the fact that most of their information came from television shows and front page of New York Times and Newsweek stories and the U.S. News and World Report, where they talk about face transplants and CPR being effective and other things like that. So I really think that we are accountable to know the data, to collect the data, to inform the families. And I think that I actually disagree with David's assertion that the families should be allowed to just make whatever decision they do based on emotion. I know that that comes into play. But I think that we have to see the decision-making process as a process. It is not a one-time conversation, that there are all kinds of things that wash over the families as they're presented with their situation, with the data. The way we present the data, if we give it verbally as opposed to in a pie chart of statistics, is much less effective if we do it verbally versus in a visual way. So we have to take some responsibility for that. I mentioned earlier about videos and really seeing what the situation is that they may be choosing for themselves unknowingly. And I think just throwing them into that without giving them that kind of information is really profoundly unfair and inappropriate and unethical. I think as well that they really need some empathy and they need some time to discuss with their extended family, with their religious advisors, with their community members, what they're going to be doing given the data that we provide to them, the hard data that we might know. And I want to invite either Michelle or Jen, who are the grandmother and mother, respectively, of 24-week preemies who are now 3.5 years old and still on feeding tubes, but bright spellers and mathematicians, if they wanted to maybe comment about the idea that they should be cast to the wind in the decision making, or whether they need some more guidance from data.
This is what happens when you talk to somebody very quickly at coffee break. Actually, I'm the grandmother. My daughter is here with me. We're probably the only non-medical people in the audience today. It was well worth the price of the ticket to get here. This has been absolutely phenomenal. The question was, would we like the statistics or just be kind of left to the wind, I think is how I heard it phrased. Actually, as the family, we need both. And what I heard from Dr. Woodrum was something a little different, that I was hearing it's not that the parents want to ignore the statistics, it's that we interpret them differently. When you tell me that my 24-week preemie boys have got a 20% chance of life, it doesn't mean anything to me. It's a statistic on a large population. I want you to tell me what's going to happen to these boys, not a population of a similar set of numbers, what will happen to these boys. And that's the one thing you can't tell me. You can't give me a promise of how all this NICU experience is going to come out. So as a parent, since we can't be told how the story is going to end, what I need to know is some of the facts, the statistics, the numbers, give me the raw data, but then give it to me with empathy so that I can make the emotional decision. It's not void of the numbers, it's in partnership with it. So I'm not depending on either one. And the one piece that we get from you, because we stare and take in every little nuance of the medical team, what I'm looking for is an element of hope. I'm not looking for a promise. I'm just looking for something that tells me that the 20% is worth going for. Might not get there, you're not promising, but I might make it. So that's what I took out of it.
So thank you very much for that.
I think we agree.
Yeah.
I think we agree.
Yeah.
You and I agree.
You've been watching speakers from the 2010 Pediatrics Bioethics Conference. Tiny Babies, Large Questions. Ethical Issues in Prenatal and Neonatal Care. Presented by the Truman Katz Center for Pediatric Bioethics at Seattle Children's Hospital. For more information about this series of programs, please go to www.seattlechildrens.org/bioethics.
It just lets you put things in perspective. You want to take one step back to look at a total picture and not just the tiny baby you're taking care of.
Any kind of information we can get and share back with the staff helps to make us provide a better patient experience.
I'm actually okay with people coming to a conference like this and leaving with more questions than they started with. I think that's a good thing.